Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
Off-label therapies have not been approved for the use specified in this activity. This information should not be considered as a recommendation for the use of a drug outside of the recommendations in the currently approved prescribing information. This activity includes discussion of off-license or unapproved therapies. Please consult your local SMPC or its equivalent for further information.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Madrigal Pharmaceuticals.
Silent but sweeping. Liver disease is affecting nearly 1/3 of adults in Europe, often without any warning, whilst the threat of associated cardiovascular disease, diabetes and fatal liver failure quietly mounts. What begins as MASLD, an excess of fat deposited in the liver from metabolic dysfunction, can escalate to MASH, metabolic dysfunction-associated steatohepatitis. In MASH, ongoing inflammation and liver cell injury drive the development of fibrosis or scarring in the liver tissue. Fibrosis is not only a marker of liver damage, but also a key predictor of outcomes. Evidence now shows that MASH cases are rising fast across Europe, making early detection and treatment vital. In this episode, we'll uncover what puts patients at risk for MASH and liver fibrosis, why watchful waiting is no longer an option, and how we can improve outcomes for those at high risk of progression. Welcome to the first episode of our Medscape CME TV docuseries, Breaking the Silence, Tackling Liver Fibrosis in MASH, Who to Treat with Novel Therapies. I'm your host, Sharon Thomas. To learn more, Medscape headed to Germany to visit MASH expert Dr. Frank Tacker, Professor of Medicine at Charité Universitätsmedizin, Berlin. Dr. Tacker, welcome. Thank you so much for joining us.
Thank you so much for having me. It's a pleasure.
So I understand you see quite a few patients with MASH here in your outpatient clinic.
Yeah, we are a tertiary referral center with a dedicated liver clinic. Between myself and my colleagues, I'd estimate we see about 16,000 patients or so per year. Some of these patients have other liver conditions such as steatosis or cirrhosis related to viral hepatitis or alcohol-associated liver disease, but many of our patients do have MASH.
How long have you been focused on MASH?
I'd say most of my career, so at least 20 years or so. And we have certainly better tests and treatments now than we did back then. When I first started, we did not really understand how metabolic dysfunction contributed to liver disease. And it's remarkable to witness the expansion of knowledge and innovation in this space.
Ever humble, Dr. Frank Tacker has done far more than witness the expansion of knowledge in MASH management. He's a driving force behind it, authoring hundreds of publications and leading global collaborations to advance early identification and management of MASH. Let's find out more. From your perspective, how has our understanding of MASH really developed in recent years?
When I started in the field, we used to call the disease non-alcoholic steatohepatitis or NASH because we really didn't know what the disease meant.
Right, and if I recall correctly, the shift from NASH to MASH does imply that we really need to look beyond the liver.
Absolutely, that's the case. Not only are patients with MASLD at risk for liver-related adverse events, but they are also more likely to develop cardiometabolic complications such as cardiovascular disease, chronic kidney disease, or type 2 diabetes. We now understand that MASH doesn't happen in isolation, but is a key driver for cardiometabolic and liver-related complications. We believe that by targeting fibrosis in the liver, we can also benefit the patient's overall metabolic status and health.
Of course, why is staging of liver fibrosis such a critical factor in guiding care?
Yeah, fibrosis stage is the strongest predictor for liver-related outcomes. And it seems that patients, if they reach stage 2 fibrosis or moderate fibrosis, the risk of decompensation, portal hypertension, and liver cancer increases substantially. And that becomes even more relevant at stage 3. So moderate fibrosis also marks the turning point when cardiovascular mortality begins to outpace liver-related deaths for most patients. Early identification is therefore essential for effective interventions.
How have recent developments in therapy influenced your management strategy?
Oh, they have influenced that quite a lot. Until very recently, no specific therapies were approved for the treatment of fibrosis in MASH. And all pharmacological strategies that we had were used off-label with very limited and inconsistent efficacy, sometimes even with significant tolerability issues. So we often reserve them for advanced diseases or specific conditions. But now with new therapies that are safer and more effective, there is an urgency and also a responsibility to intervene earlier, which starts by identifying patients at or before stages 2 and 3 of fibrosis.
How would you say this is impacting day-to-day patient management?
Well, fibrosis is the central prognostic marker. And our guidelines now recommend case finding for significant fibrosis in all patients at high risk for MASLD. And we focus on patients either living with type 2 diabetes, abdominal obesity plus another cardiometabolic risk factor, or repeatedly abnormal liver enzymes. That means that routine screening in the general population is not recommended given the high proportion of low-risk MASLD and concerns over cost effectiveness.
The consensus guidelines that Dr. Tacker is referring to are the EASL, EASD and EASO guidelines on the management of MASLD, and he was the chair. These guidelines, along with others, encourage broader-based screening for MASH, recognising the bidirectional and intertwined relationship between liver pathology and systemic metabolic health. MASH is a serious problem because it drives progression to liver fibrosis, cirrhosis and ultimately liver failure or liver cancer. It also dramatically increases the risk of cardiovascular disease and early death, especially as fibrosis advances, which is why the guidelines emphasise early identification and intervention for those at risk. Watchful waiting may have made sense when treatment options were limited to off-label therapies with modest benefit and tolerability issues. But now the first treatment for MASH has been approved in Europe, resmetirom, which targets liver fibrosis directly and can halt and in some cases reverse fibrosis. Additional agents targeting underlying metabolic dysfunction are in development. And we are also now having more effective medications for treating the comorbidities often associated with MASH, such as type 2 diabetes and obesity. On that note, let's hear Dr. Tacker's thoughts on lowering barriers to coordinated care and expanding the MASLD community of practice. Where would you say the opportunities are within the health system to identify people living with MASH and significant fibrosis?
Well, for me, it's most important, first of all, to raise awareness about the non-invasive testing that we have for MASH now across the different disciplines and to integrate the clinical pathways. Clinical assessment for at-risk MASH needs to begin well before the patient enters a liver clinic. So fibrosis can be detected early, and each healthcare encounter for a person living with diabetes or cardiometabolic multimorbidity is also an opportunity for that assessment. I recognize that it requires more resources in the broad expansion of testing, but it's important for clinicians to know that liver biopsy is no longer the standard approach for staging MASH in clinical routine. Instead, the current guidelines recommend using a combination of non-invasive tests for staging fibrosis. My hope is that these easy first-tier tests can be integrated into routine blood and imaging tests during existing healthcare visits. Our goal should be collective and patient-centered, to identify quickly and safely individuals with at-risk MASH and to intervene as early as possible, while also avoiding unnecessary referrals and procedures for those who are at low risk. I suspect this audience may already appreciate many of these points, when looking at this.
Of course, but it's also possible that some viewers really have to learn exactly how this can be done. And it's my understanding that the referral pathway at your institution is really an exemplary model of multidisciplinary liver care. I believe it's called the liver checkup.
Yeah, that's correct. We started with a small group of outpatients clinics about 3 years ago. Since then, we have expanded into a broader network. We accept patients from any physician, in theory, and work closely with our colleagues in cardiovascular disease, diabetology, and gynecology.
Why gynecology?
Well, to find patients who are at risk from gestational metabolic issues or from postmenopausal risk factors.
I see. Can you walk us through your referral pathway?
Yes, of course. It's been through several iterations, but the objective has always been the same: to use non-invasive methods as the foundation for early detection of liver fibrosis. At our referral centers, we ask the physicians to conduct easy tests such as the FIB-4 test in a patient with suspected MASLD. FIB-4 is a very low-cost, widely available method to rule out significant liver fibrosis. It uses patient's age and routine laboratory tests, AST, ALT, and platelet count. If the FIB-4 score is less than 1.3, those individuals are very low risk, can be safely reassessed in 1 to 3 years. If their FIB-4 score is greater than 1.3, they are referred to us for additional testing because we suspect relevant liver fibrosis.
And what happens when they arrive here at the liver clinic? What can they expect?
When a patient is referred to us, we review all the available lab data and piece together the clinical picture for risk assessment. And next, we usually conduct elastography of the liver, most commonly vibration-controlled transient elastography, or VCTE. Would you like to come and take a look at our metabolic clinic?
Love to. Yes, please. It's just a short walk down the hallway here at the hospital to the metabolic clinic.
We use VCTE to measure liver stiffness as a surrogate marker for liver fibrosis. And if we can clarify that the patient is not at immediate risk of progression, they will stay under the management of the primary or secondary care physician. Otherwise, they will come to us, to the tertiary clinic, for management. A liver stiffness measurement, or LSM, of less than 8 kilopascal typically rules out advanced fibrosis, while any liver stiffness greater than 10 kilopascals rules it in. Large international studies have shown that progression to an LSM of more than 10 kilopascal increases the risk of adverse liver-related events by 400%, while regression from above 10 to less than 10 reduces them by 75%. An LSM equal or greater than 10 kilopascal is strong evidence of significant or advanced fibrosis. And as I mentioned earlier, fibrosis stage is the strongest predictor of liver-related outcomes. That's why it's so important to identify patients with at-risk MASH and treat them with new therapies that can slow the progression of fibrosis or can even improve it.
What if the patient's LSM falls into the diagnostic grey zone between 8 and 10 kPa?
This is not too uncommon, I have to admit. And when this happens, you wonder, can there be confounders for the liver stiffness? We're able to minimize the impact of confounding variables in LSM by having patients fast for at least 2 to 3 hours before the examination. You also want to consider obesity as a potential confounder, and for this we have alternative probes to assess the liver stiffness. If doubt remains, we can also add another complementary non-invasive test, or we can simply repeat the liver stiffness assessment after 3 to 6 months, which will help us to confirm the results.
Let's recap. Adults with non-cirrhotic at-risk MASH who have moderate stage 2 or advanced stage 3 liver fibrosis can now be treated with new liver-directed therapies like resmetirom as part of a comprehensive lifestyle and metabolic management programme. Liver biopsy is no longer routine given its impracticality. Instead, non-invasive testing can be used for treatment planning. A VCTE measurement of 10 to 15 kPa is consistent with significant to advanced fibrosis, whilst 8 to 10 kPa warrants confirmation with complementary non-invasive testing. And how reliable is non-invasive testing in your view?
Well, those non-invasive tests not as accurate for detecting stage 2 versus stage 3 fibrosis or higher, but they become more and more reliable as the fibrosis advances, and they are now part of the clinical routine care. Repeating the same test over time or using different complementary tests sequentially can also boost diagnostic certainty. Sequential FIB4 VCTE has shown 99.5% negative predictive value to rule out future liver-related complications and ensure timely treatment for those at most risk. Specificity was 87% for high-risk classification of liver-related events over 5 years. However, non-invasive tests are not substitutes for biopsy if there's clinical suspicion of alternative diagnosis such as autoimmune hepatitis or indeterminate fibrosis stage. In those situations, liver biopsy may still be needed for the definitive histology. And we also need liver biopsy in clinical trials that require an absolute accurate staging and grading in response to a therapeutic intervention.
How would you handle other challenges, for example, if VCTE were not available?
Well, the guideline recommends a whole list of alternative non-invasive testing approaches that are available, starting with the FIB4, and if testing suggests intermediate or high risk, using a second-line test such as the Enhanced Liver Fibrosis or ELF test is an option then. It's a serum biomarker with a good accuracy for detecting significant fibrosis. It can also be used as an alternative or in combination with other blood panel results. It's a bit costly, but particularly useful for treatment planning. Other imaging-based options beyond the liver stiffness measurement by elastography include the shear-wave elastography, which is ultrasound-based, or magnetic resonance elastography, which is MRI-based. Although these have limited accessibility and probably also higher costs. If neither of the advanced imaging or ELF test is available and the risk remains indeterminate, you can repeat FIB4 or the NAFLD fibrosis score test annually or refer the patient to a hepatology clinic for further evaluation if there's ongoing suspicion of advanced liver diseases or if the risk factors persist.
What sort of challenges have you faced with implementing the liver checkup referral pathway?
Yeah, a major issue has been the lack of reimbursement in Germany for non-invasive tests like elastography. Liver biopsies are covered, but second-line non-invasive tests are not. So we are reimbursed for the general visit, but not specifically for the diagnostic tools that we apply. Eventually, the system will catch up with current evidence. And although the elastography may seem initially expensive, data show that it leads to substantial long-term cost savings.
Dr. Tacker, this has been hugely illuminating. Thank you so much for joining us. Thank you.
Thank you. I've enjoyed it very much. Thanks.
Thank you for joining us as we explored the growing crisis of liver fibrosis and the advances transforming its management. As we've learned, timely identification and non-invasive testing are key to catching progressive liver fibrosis before it causes irreversible harm. With better tools and coordinated pathways, we have an unprecedented opportunity to intervene early and to improve outcomes for those at greatest risk. In our next episodes, we'll learn how leaders in the field are approaching treatment in complex real-world cases. You won't want to miss these insights. For this episode, remember to complete the post-activity quiz and evaluation to receive credit. And let's continue to champion innovation and collaboration, because by breaking the silence, you can improve outcomes for patients with MASH. Until next time, take care.